A very good evening to one and all. At the outset, I like to thank Dr. Dinesh Talwar sir for giving me this opportunity. I'll be speaking on OCT angiography, what all it can show. I'm going to make this talk very simple because the target audience is general ophthalmologists. So I won't be going into much detail about the technology, but I'll show you examples where it can show us the findings that we can take out from the OCT angio. OCT angio takes sequential OCT scans at the same location on the retina, that is around 70,000 scans per second. And it uses the motion of the RBC that is moving in the blood vessel. And the surrounding retina is static. So it is the difference between the movement of the RBC and the static retina which gives us the images. And it is based on the SSADA, that is SADA algorithm, that is the OCT signal is split into 4 or more spectral bands, and each spectral band gives a different speckle pattern, and combining this you get a independent information on the flow. So basically OCT has been a game changer in the retina practice, and the FA use has come down because it has side effects also, but FA is very important because it will give us information about the flow, about the capillary dropout area, about the retinal perfusion, but it has side effects. And you just get FA in one single layer. You cannot segment the vasculature. But with the OCT angio, this is possible. So this is the superficial layer. This is not an FA. This is a OCT angio image. So this is a superficial layer of the retinal vasculature. You can see there's a continuous perifoveal arcade with regular meshes. And the layers imaged are RNFL, ganglion cell layer, and the superficial IPL. And the deep layer is much more denser. It's more close-knit pattern of vessels distributed around the FAZ. The outer retina normally does not show any blood vessels, and the choriocapillaries is not that well imaged, but you get a coarse texture here. So these are the various layers of the vasculature that can be imaged by the OCT-A. Now we'll see a few cases. This is a diabetic retinopathy. It's very obvious there is a neovascularization at the disc. If you do an FA, that it picks up very well, but you don't get the information. You don't get the architectural details of the NBD because of the profuse leakage. But you look at the OCT-A, you get excellent images of the architecture. You can really see the network of the NVD, and you can get the various layers. You can image the new vessels at the nerve head, at the vitreous, and at the radial peripapillary level also. And you can document the regression post laser. So the down images, you can see it has regressed after the laser. And the FFA OCT in diabetic retinopathy, the left side image is the FFA, and OCT gives you comparable images. There's a better visualization of the venous beading and looping. You can see this is the venous beading and looping as compared to the FFA. It is better seen. And there is a good correlation of the capillary non-perfusion areas also. But the microaneurysms are not seen. Some microaneurysms are picked up and some are not picked up. That will depend upon the flow of the blood that is present in the microaneurysms. And this is a case of diabetic retinopathy with macular edema. So you can see the OCT angio. This is the superficial layer of the retina. You can appreciate the distortion in the FAZ. The FAZ is altered, and there is a corresponding. This is the NFAS. So you can see the cystoid changes. So NFAS also gives very good images. So basically the take home could be in diabetic retinopathy, if you are in doubt whether it's a new vessel or a IRMA, that is interretinal abnormalities, microvascular abnormalities, you can get an OCT-A done. In that case, it can tell you, or if you're doubtful whether you're dealing with a NVE, so you could do OCT-A. And in cases of diabetic macular edema, at each visit you can do the OCT-A. It can tell you about the progression or worsening of the macular ischemia. This is a case of BRVO. This is the superficial retina. You can see the vasculature is very nicely seen. The upper part of the vasculature is not well seen because of the edema. And this is the corresponding OCT. You can see the cystoid macular edema. And this patient received anti-VEGF, and you can see the improvement in the OCT-A after the treatment. And the OCT also shows improvement. And you can map the capillary non-perfusion areas. It comes with an inbuilt program where you can give a color code to the CNP areas and you can map them. You can quantify them. So there's a good correlation of capillary non-perfusion between FFA and OCT-A with non-flow measurement tool. And we just recently had this publication, the IOVS, so where we could quantify the vessel density by OCT-A. So it's a mathematical model on fractal analysis. So it's a good tool to look at the vasculature, how dense the vasculature is there, what are the alterations in the FAZ. So all these things can be studied. And central serous chorioretinopathy, this is the ICG image. And this is the OCT-A image. Superficial retina looks okay, but if you look at the choriocapillaries level, there's an alteration in the architecture. There's a change in the architecture as compared to the surrounding choroid. Because we all know that in CSR, there is a hyperdynamic and hyperpermeable choroid. So that is reflected here. And the edema also will play a part. So you can make it stand out, you can mark that area and measure that. So this is a case of CSR pre-treatment. You can see the subretinal fluid, and this is post-treatment. There's a change or improvement in the texture at the choriocapillaries level. And this is the case of CNVM at the level of choriocapillaries. You can see a nice grid of vessels is seen, fine vessels. And this is the corresponding OCT that shows the CNVM complex with intraretinal and subretinal edema. And this is at 1 week. There is some improvement. The network has reduced. And this is at 1 month. So there's a good improvement. So it is, each visit you can do this. FA is not possible, but this will tell you how it is regressing. And this can be measured. You can measure the area of the membrane. You can measure the vessel area. So it can add to your treatment. And MACTEL is a very interesting disease. The pathophysiology is not very well understood. The FA shows typical features, but you cannot really look at the vasculature because of the leakage. But OCT angio will show us what happens in MACTEL, how it progresses. So recently we had a publication on this. We characterized the characteristics and quantification of vascular changes in MACTEL type 2 on OCT-A. So basically, we studied 56 eyes with MACTEL. They underwent fundus photography, SD-OCT, and OCT-A, and mean capillary density was calculated using a MATLAB-based automated software. And the results that OCT-A showed an increase in the intravascular spaces with progressive capillary rarefaction and abnormal capillary anastomosis. These anastomosis you cannot really appreciate on the FFA. And the outer retina and choroid were involved during the later stages and showed a prominent vascular network. And the mean capillary density of the superficial and deep layers was less. So we concluded that OCT-A helps understand the pathology and disease progression better in MACTEL 2. So this is a case of MACTEL. You can see there are large enlarged blood vessels in the superficial retina. The FAZ is altered. There is the fine network of the FAZ is not seen. And this is at the deep retina. And this is at the outer retina. Outer retina usually normally does not show blood vessels. But here there is a abnormal blood vessel is seen because this case had a CNVM scar. And this is the OCT at the level of choriocapillaries. So basically there is an increased intravascular spaces, decreased capillaries, abnormal tortuous vessels, abnormal vessels in outer retina and choroid in neovascular scars. And PCVA is also a very interesting entity. So you can see the ICG that shows the typical polypodal changes, and the OCT also shows characteristic features that suggest PCVA. And this is again the enlarged view on the ICG. You can see the classic polyps, and this is the at the choroidal level OCTA. Unfortunately, it does not pick up the polyps, but you see a hypofluorescent area around the polyp. So based on OCT angio, it could be difficult to plan your treatment. You cannot really treat the polyps. And we had a very interesting case. This is a central retinal artery occlusion with sparing of the coeloretinal artery. You can see the box scarring, cherry red spot. This part of the retina is perfused. This is the FA that shows that coeloretinal artery is spared, but unfortunately the fovea is not supplied by this. So this patient, this is the OCTA. It shows similar features as compared to FFA. And this patient underwent paracentesis. So you can say immediate post-paracentesis, there is improvement in the blood supply. So this could be important for follow-up after paracentesis. So because repeatability is not a problem with the OCT angio. So to conclude, OCT angio is an exciting new technology. It can visualize the retinal vasculature without injecting any dye. It is known as dye-less angiography also. And segmentation of the vasculature is possible. And it can be repeated as many times as you want. But it needs a cooperative patient. It has a limited dynamic range. If the blood flow is fast, it's going to miss it. And it's difficult to interpret. It takes time and experience. And small area of the fundus is imaged. Mostly we work on 3x3 images, but maximum at present is possible is 8x8 images. Thanks.